I will present the data of the 3 first cohorts. And this is a total of 82 patients who were included in these 3 cohorts. And just to make things short, the best results and the most safest and most effective regimen for treatment with navtemadlin was actually the 240 milligrams, 7 days, every 4 weeks. And we will see that later. If you just look at the patient characteristics included in this trial, and I think it is always very important to look at patient characteristics to, put results in a right context. You see the median age is 69 years, and this is the typical age of patients we see at least in Europe and in the United States with myelofibrosis. Many of these patients were intermediate to and high risk, again, not by IPSS, but by DIPS, the dynamic IPSS risk score. So these were really advanced disease patients. The majority were refractory and relapse. As I said, no intolerant patients were allowed to be included in this trial. Around 25% of patients had platelets below 100. Mind you, this is also important. Patients with platelets below 50 were not allowed to be treated with navtemadlin. This is again very important to remember, that patients from platelets 50 and above could be treated with navtemadlin. And again, what is quite important, and this is something I found a very positive aspect, and we could discuss about that in this phase 2 trial, there was no required washout phase for the JAK inhibition before starting with trial treatment. And all other trials always require a minimum of 2 weeks up to 4 weeks of washout of JAK inhibition before starting with a trial medication, because you are all aware, because of the rebound and the flare we might have when we discontinue JAK inhibition with the spleen and the symptoms, which will or might confound trial results. For the sponsor, this was not a very good thing, but from a medical point of view, it was very, very comforting, a comforting issue, because we all know how patients suffer, even if we believe that they are refractory or relapse to JAK inhibition. And if we discontinue these treatments, patients really feel very bad. And we do have many issues in this washout period. So here there was no washout, and this is important when we look now at the results. Next slide, please. So this is response. As I said, this is a phase 2 trial, and the spleen response, if we look at the spleen response overall, we have a spleen response of at least a reduction of 35% by MRI from the baseline in only 16% of these patients. But as I said, the results of this trial were actually confounded by the lack of the washout, because, when the baseline MRI was done, patients were still on JAK inhibition. And then day 1, they started with navtemadlin. And in the meantime, until MDM2 inhibition was working, patients had a huge increase in the spleens. And so if you look at the 2 groups separately, the ones who were on ruxolitinib at the start of, or day -1 prior to the start of MDM2 inhibition, the response in these patients mounts up to 30% compared to actually 0, especially at week 12, for patients without a washout period. Regarding total symptom response, at least 30% of patients had at least a 50% reduction at any time while they were taking the medication compared to baseline. Next slide, please. Interesting is, and again, we have to be careful, these are phase 2 data, still limited number of patients, but there are some interesting observations. There were some interesting changes in biomarkers of the disease, for example, the allele burden. And indeed, in 30% of patients, there was at least a 20% reduction in the allele burden relatively early under treatment with MDM2 inhibitor navtemadlin. And what is interesting is that it seems to be a clinical correlation between the spleen response, the symptom response on one side, and the reduction in the allele burden. As I said, small number of patients, but an interesting observation. Next slide, please. To me personally, this is one of the very interesting findings of this trial, namely the dramatic reduction in the circulating CD34 stem cells when treated with navtemadlin. And you can see that really after 1 week, actually, patients, let's say with blast 7 or 8%, a week or two later, in many of these patients, you will see no blast. And we could see that we have actually a reduction of almost 90%, particularly when patients are treated with 200 milligram per day for the 7 days, every 4 weeks. And this is really dramatic, and it is sustained up to month 6. This is the median follow-up time of this trial. And again, interestingly, it is not just the lab finding. There seems to be a correlation between this reduction in blasts with clinical benefit in terms of spleen volume reduction and total symptom improvement. Very interesting and very dramatic finding. And the same is true for the LDH, which we observe in our patients, which again normalizes quite rapidly and dramatically in many patients. Next slide. And again, we have data to cytokines. I just chose TNF-alpha as an example, that again, we have a good reduction in cytokines under treatment, particularly again in the 240 milligram cohort. And again, there seems to be a correlation between the reduction in cytokines, which is actually no surprise, to the clinical response in spleen and in symptoms. So these are very interesting findings, and there are some preliminary findings about bone marrow fibrosis, although I am always very cautious about these findings because they're still much too early and we need much longer time to really interpret these data and put them into context in terms of, you know, progression-free survival or survival. Next slide. Efficacy is always one side of the medallion, but we have to know safety. And the main adverse events are actually gastrointestinal in terms of diarrhea, nausea, and vomiting, but also hematological toxicity. And if you look at all patients in all cohorts, almost all patients had some kind of GI adverse event. And this is a relevant issue. And I think with time, we have learned how to better monitor and manage our patients and what GIT mitigation strategies like the use of anti-diarrheal and anti-emetic therapies prophylactically to better let patients tolerate the treatment. Regarding thrombocytopenia, grade 3 or 4 is again occurring in around 1/3 of patients. And anemia, well, just as a reminder, patient characteristics, 60% of patients had NF-related anemia at baseline, and nevertheless, we do have also transfusion dependency and anemia occurring under treatment, and this is no surprise in around 30% of patients. But I think anemia is not a big issue. Thrombocytopenia should be looked at, especially in the early phases of treatment. Neutropenia, leukopenia could occur, but this is a smaller issue in the majority of patients. Next slide. And again, the tolerability was best for the 240 milligrams 7 days every 4 weeks cohort. And nevertheless, if you look carefully, in most patients, actually, we needed some kind of dose reduction or dose interruption. And the withdrawal was rather high, mainly because of adverse events or investigator decision. As I said, we are learning to better mitigate, particularly the GI adverse events. Next slide, please. With this, I will come actually to the summary of the data. The 101 trial is actually the first clinical proof of concept study showing the important role of MDM2 and its inhibition in patients with myelofibrosis. And navtemadlin has demonstrated a dose-dependent relationship for both safety and efficacy, with some promising clinical activity and tolerability in patients, again, refractory or relapsed MF to JAK inhibitors. And clinical measures, biomarkers of myelofibrosis disease burden support navtemadlin at, as I said, 240 milligram day 1 to 7 every 4 weeks as the optimal dose and schedule for patients with myelofibrosis, and the reduced driver allele burden, peripheral CD34 cell counts correlated significantly with spleen response and symptom response, as well as the cytokine reductions. But again, as I said, phase 2 trial, and we always need to have the data of a large phase 3 trial to confirm these data and to show the potential of disease modification, but also clinical response, quality of life of patients with MF. And with this, I would like to thank you very much. And I think this is my next slide. Thank you very much.